I would do a video about stoma and then peristomal skin health. I was going to split it into two halves just to cover both equally, and I figured I would stick to the basics. Usually there are certain things that ostomates deal with pretty commonly, and then there's stuff that is a little bit more rare that I'm not going to go into too much. I will mention it, but because I haven't experienced it myself, I'd rather not share it. I feel like I don't have enough information about it. And those kinds of things, when I mention them, they're usually more emergent things that you would go see your surgeon or your stoma nurse for. You guys know that I really, really want to be a WOCN, or at least a stoma nurse, but unfortunately you cannot apply to school for that until you've been a registered nurse for 1 year. So I'm 6 months in, I'm halfway there. I'm really, really wanting to do it so bad. Just the kids that I work with on the GI floor that have ostomies and IBD as well, I just really, really enjoy talking to them and their families. I really feel like I get a lot out of it, and I'm hoping that I'm helping them too, just with my experiences. So I'm really looking forward to that. But let's get into the video, and I'm hoping this gives you some information about your ostomy, and maybe it can help you. Okay, so we are going to talk about the stoma first. And there is quite a few different things that can happen with the stoma. It can prolapse, it can have trauma to it, it can separate from the skin, there can be necrosis with the stoma, there can be retraction, which is kind of the opposite of a prolapse, and then of course obstruction, stricture, which I feel like a lot of IBD people are familiar with. So I'm going to go into a few of these in more detail, but basically when you have a stoma, there are a few things that you and your nurse are looking out for, particularly with a new stoma. So you want to make sure that it has a beefy, red, moist appearance. You want it to have that red appearance because the intestines are, I don't know the word for this, but there's a lot of blood in the intestines, and you want to make sure that there is enough blood flow getting to it. That's why one of the issues can be something called necrosis, where the stoma has a lack of blood flow and winds up turning dark. It can be purple, it can turn eventually black, and that's when we know that the intestine has lost all blood flow and is not able to function, and that is an emergency. Another thing that we look out for is the size of the stoma, or the length of it. An optimal length for a stoma is usually if it sticks out maybe ½ an inch to an inch, just so that it kind of pokes into the bag and the output can go down into the bag. One of the complications is something called prolapse, which means that the intestine actually starts to come out longer and longer, and it can fill the bag. I've actually seen this in one of my patients, and it's pretty interesting to see. It's usually not painful, and it can sometimes be reduced whether surgery does it, or sometimes the patient can actually push the stoma back in, and it doesn't cause pain, but it is, you know, it's kind of a problem if your stoma just keeps coming out and filling the bag, because where does the output go? So that's one of the complications that sometimes people see. Now the opposite can happen, where it kind of retracts and gets flush with the skin, or even sometimes goes further into the abdominal wall, so we can't even see the stoma itself. And that makes it difficult for a bag to stick because, you know, if it's flush with the skin, it can just leak straight down in between where the flange sticks to the skin. So that's not optimal either. And what people wind up doing is using convex bags. They're kind of rounded wafers that push and put pressure onto the skin around the stoma to try and encourage the output to go into the bag. Sometimes it works, sometimes it doesn't. One more serious thing that happens is when the stoma actually separates from the surrounding skin, so you can see a gap. I have not seen this on any of the kids that I've worked with. I haven't seen it on myself. I've seen pictures online, and that is something for your surgeon to take care of. Usually what they wind up doing is using dissolving stitches, and for whatever reason, if it doesn't heal quickly enough, or if the stitches dissolve too quickly, the stoma hasn't healed to the skin, all the tissues haven't connected yet, and the stoma separates a little bit, so there is a gap, and that's something to see your surgeon about. Usually you can clean it with a little bit of sterile water if you're concerned about it, but let them deal with it. That's not something as an IBD YouTuber that I can help you with online. And then occasionally, the last thing I'll talk about is trauma to the stoma, which I think a lot of people are more concerned about than they need to be. You definitely need to be careful with the stoma. You don't want anything hitting it or scratching it or anything like that. But I think people don't understand the resilience of the stoma. I have unfortunately gotten kicked in the stomach, and won't go into my stories at work, but I have gotten kicked right in the stoma and been totally fine. They are pretty resilient, but I don't recommend doing that, of course. They make protective belts which work awesome. They kind of create this dome over the stoma just to protect it, but sometimes the stoma does get trauma to it. And one of the little signs that we see is either bleeding, which stomas bleed a lot since the intestines are supposed to be full of blood. Even just touching it can cause it to bleed. But you might see a little bit extra blood, and then as it heals, you might see a little bit of like a white, yellow sort of tissue wherever the laceration or trauma occurred. So that's it healing, but that's something to look out for too, because a while ago, probably 5 or 6 years ago now, when my stoma was newer and I was still kind of learning about it, I had seen this yellow tissue and I was like, what the heck is that? And I realized now it was from when I was pouching my bag. You know, I maybe didn't cut the hole wide enough or whatever, and it just kind of sliced the stoma, and it was right where the stoma, where the flange hits the stoma. It was right there where I had this like little bit of yellow tissue, and it wound up healing and going away within a few days. So just to remind you, you want to look out and make sure that your stoma is staying roughly around the same length, the same width, having that red, beefy, moist appearance. Always a good sign. It's great to keep checking your stoma. I know that in the hospital they automatically put clear bags on you because they want to make sure they can see your stoma. But as you get home and you're adapting at home, you can always change to clear bags. But you just want to make sure every time that you're changing your ostomy pouch that you are taking a good look at your stoma and making sure that things are staying the same as they were the last time you looked at it. And then if you have any concerns, you should contact your surgeon or your stoma nurse to take a look at it. Alright, now we're going to talk about the peristomal skin conditions. And there's things like contact dermatitis, granulation tissue, folliculitis, candidiasis, fistulas, pyedoma, gangrenosum, pressure ulcer, and hernias. So I'm only going to talk about a few of those because I'm talking about the ones that I've experienced myself. But there are quite a number, I mean there's more than I listed there, of peristomal skin conditions. But I figured let's talk about the ones that we'll mainly see. So one of the main ones is contact dermatitis. There's two different types. There is allergic and then there's irritant. So the allergic is the less common one, where we are physically allergic to the bag or some product that we are putting on the skin around it, and it's causing irritation around the stoma. Now the irritant is more common because it's usually related to our output. The enzymes in our output irritate the skin. And you know, everybody has a bag that leaks at least once in having an ostomy bag. And unfortunately, the output does really damage the skin. And that's why we see irritant contact dermatitis. And that's why they recommend using skin barriers with contact dermatitis, just to create that barrier to protect the skin from the flange or your output. Using stoma powders, which I think pretty much every company makes now, just to create another barrier but also help heal the skin. And they do work great. I recommend putting on a layer of skin barrier, then putting on the powder, and then another layer of skin barrier, creating kind of a sandwich. The reason I do that is when I put the skin barrier on first and then I put on the Stoma powder, it sticks to the first layer of skin barrier. But of course, powder is going to make your flange not stick, so that's why we put on the second layer. And I found that really works, and it does heal the skin very well within a short period of time. Another thing that's seen with the peristomal skin is something called folliculitis. And this is basically when the hair follicle gets irritated, infected, and it kind of looks like a little papular, kind of like a pimple, essentially. And it can be a little bit painful, but they usually heal on their own. I've never needed to do any treatment with the ones that I've had. I've had them both around my stoma and then also around my scar. I don't know why I get them around there a lot, but I do. It doesn't really need any treatment, it just needs to heal on its own. And then the last one that I'm going to talk about, which I dealt a lot with this past summer, is candidiasis, which is basically a yeast infection. I noticed it not so much around the immediate peristomal skin, but actually more around the outer edge of my wafer, right where the fabric was. And my problem was, I would take a shower, the fabric would get wet, it would have to dry in the summer, and it was humid already, and it was just hot, so it would stay wet for a while, and I wound up with this just horrible redness, which you can actually see in some of the pictures that I posted as like the titles. You'll see redness around the edge, and I mean, it was very painful. That was probably the most painful condition that I've had. It's just so irritating, so itchy. And I went to my GI and he said try a little bit of the hydrocortisone cream, which I mentioned in my last video. My GI recommends it, but they often recommend like antifungal powders and creams, something like nystatin powder. They use a lot at the hospital I work at, just to try and heal that up, because a lot of kids have trouble with that and it's super irritating. I hate that one. It's so annoying. So we talked about the more basic surface type issues, which, you know, can usually be helped with skin barriers and stoma powders and certain prescription powders and creams. But there are more serious problems like fistulas and hernias and pressure ulcers that really need to be taken care of by a stoma nurse or, you know, your doctor or surgeon. They need to either repair that surgically or find out how else to repair it, because it's something more serious. It's less likely to be seen as the other stuff that we talked about, but I just wanted to mention it so it's something you can be aware of, and you can you know, think about if you're having some certain issue that doesn't match up with the more common things we talked about. Okay guys, so I hope that gave you a very basic coverage of skin and stoma health. I just covered things that I've experienced myself or I've seen in the hospital, just so I know that I'm giving you the right information. I really hope you enjoyed this and learned something new and makes you a little bit more comfortable about having a stoma and living with it. So, alright guys, I will talk to you soon, okay? Bye!